Welcome to Topic 7, Disorders of the Urinary System. We'll start our discussion today talking about normal renal physiology. The kidneys function to remove metabolic waste, hormones, and foreign material from the body. They also act to regulate water, electrolytes, and acid-base balance. They secrete erythropoietin in response to tissue hypoxia to stimulate red blood cell production. They activate vitamin D, which is going to allow for normal calcium absorption from the GI tract. And the kidneys also function to regulate blood pressure in the long term through the renin-angiotensin-aldosterone system. There are three components of urine formation. First, let's remind ourselves that the kidneys are each made up of over 1 million nephrons, and a nephron is composed of the capillary beds, glomerulus and the peritubular capillaries, and the associated kidney tubule. So let's start with the first process, the filtration, and this is a process the function of which is the glomerulus. And this is a non-selective passive process in which water and solutes that are smaller than protein get forced through the capillary walls of this glomerulus. Now, blood cells and proteins don't normally pass out of the capillaries, just the filtrate. Okay, so this is essentially plasma minus plasma proteins. And the reason why the glomerulus is so good at filtrating is because we have a pretty large afferent arteriole and a more narrow efferent arteriole. And so this creates greater pressure within the glomerulus. So this greater hydrostatic pressure is going to force fluid out of the glomerulus and into the kidney tubules. The next step is reabsorption. And this is where substances move from the kidney tubules to the peritubular capillaries. Now remember, in the kidneys we have two capillary beds in series, the glomerulus followed by the peritubular capillaries. So if you think of the blood flow through the peritubular capillaries, it's lost a lot of fluid, but it hasn't lost proteins. So because it's lost a lot of fluid, the hydrostatic pressure is lower in the blood here, but the oncotic pressure is high. And remember, the oncotic pressure is the reabsorption pressure. So this is going to help to reabsorb fluid back into the blood. And this is going to help. We're going to use reabsorption. Most of this reabsorption is just going to occur not under hormonal control in the first part of the kidney tubule, the proximal convoluted tubule. So things like water and sodium are going to be reabsorbed. But later on, as we'll talk about in a little bit, some substances are going to be hormonally controlled in the latter part of the kidney tubule. Okay, and then secretion is moving from the blood to the kidney tubule. So this is a way to get rid of some substances that weren't already in the filtrate. So we can eliminate undesirable substances also that have been absorbed. So some things that either weren't filtered or that were filtered and reabsorbed, we can still secrete some of these things. And this is how the kidneys get rid of excess potassium, and is how the kidneys act to control blood pH, because they can secrete hydrogen ion at the same time as reabsorbing bicarbonate ion. So let's talk about some of the hormones that control reabsorption. So most reabsorption, as I mentioned earlier, is not under hormonal control. And most reabsorption occurs in the first part of the nephron, the proximal convoluted tubule. But some hormones can modify the absorption of certain substances according to the body's need. For instance, antidiuretic hormone, which is secreted by the posterior pituitary in response to a high osmotic concentration of the extracellular fluid, or a loss of blood volume. This hormone is going to cause the reabsorption of water in the distal convoluted tubules and collecting ducts, and this is through the insertion of aquaporins. Aldosterone, which is secreted by the adrenal cortex, this is going to cause the reabsorption of sodium in exchange for potassium or in some cases hydrogen. So aldosterone does this by causing the transcription and translation of sodium-potassium ATPase pumps. So more sodium gets reabsorbed, more potassium goes out in the urine. Atrial natriuretic peptide, this is released from granules in atrial cells in response to stretch, which would occur with an increase in fluid volume. Atrial natriuretic hormone kind of does the opposite of aldosterone in that it's going to eliminate sodium, and along with that water should follow. Let's look at some of the tests of renal function. Serum creatinine. This is a byproduct of muscle metabolism. It is freely filtered by the glomerulus, but it is neither reabsorbed or secreted. Now it's going to be lower in a small woman because she doesn't have as much muscle mass, and higher in a muscular man. Serum creatinine is good as useful as a tool to help follow kidney disease within an individual. So if it doubles, the GFR is most likely cut in half. The BUN, or blood urea nitrogen. So urea is an end product of protein metabolism. It is freely filtered, but it is also reabsorbed. So BUN gets increased with a low GFR and would be lower with a high GFR. We also have the BUN to creatinine ratio. The normal ratio is 10 blood urea nitrogen to 1 creatinine. If a ratio is greater than 15 to 1, that can indicate pre-renal conditions such as congestive heart failure or GI bleeding. Now we're going to talk about pre-renal acute failure later, so just kind of make a mental note that this ratio is indicative of pre-renal conditions. And the reason why the nitrogen changes more in pre-renal conditions than the creatinine is because creatinine is not reabsorbed. It's filtered, but it's not reabsorbed or secreted. Whereas nitrogen is filtered and it is also reabsorbed. So if the kidneys are functioning okay, rather we're just not getting much blood flow through the kidneys. Number one, we're not getting rid of much nitrogen. And number two, what we're filtering, the blood flow is going so slowly through the kidneys, we're reabsorbing more of that. And that's why that ratio increases. Now, if the kidneys start to fail, we would see a change in pH. Normal pH of the blood should be about 7.35 to 7.45. Metabolic acidosis, due to decrease in kidney function, can indicate decreased GFR. Anemia can indicate decreased erythropoietin secretion, or it could be bone marrow depression. Electrolytes are going to depend on related fluid balances. Elevated renin levels could indicate kidney as a possible cause of hypertension. This looks at some of the normal values found in a routine urinalysis. You should note that there should be no sugar in the urine, no ketones in the urine, no blood in the urine, no protein in the urine, no bilirubin in the urine. And it should be negative for like bacteria and signs of bacteria. I also want to point out the pH of the urine varies greatly from 4.6 to about 8.0. So remember, one of the kidneys' functions is to regulate acid-base balance. So it can do this by secreting a very acidic urine if we need to get rid of acid, or a very alkaline urine if we need to retain acid. Okay, moving on. Let's talk about the glomerular filtration rate. So this is the amount of filtrate formed in all the renal corpuscles, and this is the glomerulus plus the tubules of both kidneys each minute. A normal GFR is about 180 liters per day. This is equivalent to filtering your kidneys out about, I think, 50 times per day or so. The importance of, or filtering your blood, sorry, about 50 times per day, or 60. The importance of maintaining a fairly constant GFR. So let's think about this. If the GFR is too high, then substances are moving through the kidneys too fast, and needed substances can't be reabsorbed, and they get lost in the urine. If the GFR is too low, then we end up reabsorbing too much, including wastes that are normally disposed of. If the kidneys fail, then we find that the GFRs decrease and waste build up in the blood. So let's look at GFR and blood levels of creatinine, because creatinine is a great way to track kidney disease. So once again, creatinine is that byproduct of muscle metabolism. It is filtered by the glomerulus, but it's not reabsorbed, or it's secreted. So it's a really good indication of simply filtration only. Okay, but it does vary between people, as I mentioned. So it's better at tracking kidney function within a person rather than looking between people. So this plots serum creatinine levels in the blood, of course, against percent of normal renal function. So we can see that as our GFR declines, so this is declining GFR, decreased function. So GFR declines, plasma creatinine level increases. Okay, and this is because less is being filtered, and that means less is being excreted. More is staying in the blood. Okay. Question. Tell whether the following statement is true or false. If GRF increases, urine output will decrease. This is false, of course. If GFR increases, that means more fluid is moving through the kidneys, and there's less time for fluid to be reabsorbed into the blood. So if less fluid is reabsorbed, more fluid is going out in the urine. Okay, let's look at urinary tract infections. Cystitis and urethritis. These are both lower UTI infections, lower urinary tract infections. Pyelonephritis, that's an upper urinary tract infection. Common causative organism is E. coli. They have filaments that allow them to adhere to the lining of the urinary tract, and this is a place where they can get established and you can get an infection. Now, blood-borne cause of urinary tract infection is rare, but possible. Most often, the urinary tract infection comes from the lower UTI. From the lower urinary tract infection. So there's like E. coli in feces, and there can be contamination, and that can get into the urethra and ascend the urinary tract. There are various defenses to help prevent urinary tract infections, including the washout phenomenon. Every time you go to the bathroom, you wash out and potentially wash out bacteria. Protective mucus to help fend off bacteria, as well as local immune responses and mucus that secretes, not mucus, but mucosa that secretes IgA antibodies. So let's talk about some of the causes of urinary tract infections. So as I mentioned before, we could have blood-borne organisms, but that's going to be pretty rare. In women, some of the things that make urinary tract infections more common, in fact they're more common in women, include they have a shorter urethra, and the urethra has close proximity to the anus. Okay, that's why your mother always says wipe front to back. Okay, so we don't contaminate the urethra with fecal matter. Pregnancy. Pregnancy can also lead to increased urinary tract infections due to just more difficulty with normal urination during pregnancy. We see less protective mucus with aging, and we also see alterations in normal flora with both aging and with antibiotics. In older men, the main cause is prostatic hypertrophy and urinary retention. So if we retain a lot of urine, we have less of that washout, that's going to make older men more prone to UTIs. In children, this can often be caused by congenital abnormalities. In the elderly, we can get incontinence with incomplete emptying of the bladder, an impaired blood supply, so we're getting less immune cells to the area, reduced water intake. Increased fluid and washout is going to help with prevention, and immobility. Other things, kidney stones due to obstruction, immunosuppression, diabetes mellitus, that sugar in the urine can help feed bacteria, and poor hygiene. Let's talk about cystitis versus acute pyelonephritis. So cystitis, as I mentioned, is where we have a urinary infection of the bladder. Pyelonephritis is an infection of the kidneys. So with cystitis, we have a hyperactive bladder and reduced capacity. Okay, so this makes people feel like they have to go to the bathroom all the time, but they're not even going very often, or very much volume. Okay, so you feel like you constantly have to go to the bathroom, but the volume is small. It presents with pain and pressure in the pelvic area, painful urination, urgency, frequency, and having to urinate at night. There is usually some systemic signs due to the infection, such as fever, malaise, leukocytosis. Urine is often cloudy with an unusual odor, okay, and this is due to the presence of bacteria within the urine, red blood cells. The if we do a urinalysis, this indicates the presence of bacteria, pus, and some blood, microscopic blood. Pyelonephritis, we can have one or both kidneys involved. And bacteria gains access to the kidney to cause this infection, either from the lower urinary tract, so an untreated cystitis infection, that's going to be more common, or from the bloodstream, less common. This causes kind of pussy exudate that fills the pelvis and calyces of the kidneys. And with pyelonephritis, we get the same manifestations that I mentioned over on the other side here of cystitis, but additionally we get pain associated with renal disease. So now here the pain is in the back, dull aching pain in the lower back or flank area. We have the same systemic signs, but usually the temperature is higher. And then urinalysis, we find that it's similar to cystitis, although often times we can see urinary casts. And urinary casts are like molds of kidney tubules of like red blood cells, or white blood cells if they've been sloughed off, or kidney epithelial cells if they've been sloughed off. Okay, let's talk about chronic pyelonephritis. This is where we have recurrent or chronic infection that leads to scar tissue formation. This causes atrophy and thinning of the cortex, a loss of tubule function, obstruction and collection of filtrate, and this can lead to hydronephrosis, which we'll talk about later. Eventually, this can cause chronic renal failure if left untreated. Okay, moving on. We talk about glomerular disorders. So let's review the structure of the filtration membrane. We have the glomerular capillaries and Bowman's capsule that surrounds those capillaries are made up of epithelial cells sitting on a basement membrane. They are so tightly attached to one another that they share this basement membrane. Okay, so we see these epithelial cells on this capillary. And essentially we have these little pores or slits that are available for filtration. Let's talk about the development of glomerular injury. So we can have glomerular injury due to infectious microorganisms, immunological mechanisms, toxic agents, diabetes, and hypertension. However, immune mechanisms are the most common cause. There's two ways we can have injury. Number one, injury resulting from antibodies reacting with fixed glomerular antigens, or antigens that were planted within the glomerulus, say from drugs that bound to spots in the glomerulus that then created this immune response. Okay, and that's shown in A. Or we could get an injury resulting from antigen antibodies, circulating antibodies, that then get deposited within the glomerular membrane. Now these antibodies might be endogenous, such as within systemic lupus, or exogenous, as in streptococcal membrane antigens. Anyway, regardless of the cause, they can cause damage, and then that damage can lead to two disorders that are characterized based on the manifestations associated with the damage to the glomerulus. Nephritic syndromes are of acute onset, and there's gross hematuria, and this is a lot of blood in the urine. Mild to moderate proteinuria and hypertension. Nephrotic system, we have heavy proteinuria, so lots of protein. Low albumin in the blood with severe edema. Let's take a look at this next. Okay, so nephritic syndromes, these are a proliferative inflammatory response that leads to occlusion of glomerular capillary lumen and damage to the wall. Okay, so this is one of those glomerular injuries that we just talked about. This can be a renal-limited primary disorder, or it can be secondary to systemic diseases such as lupus. So the inflammatory process damages the capillary walls, and we get red blood cells that escape into the urine. So this leads to hematuria, so large amounts of red blood cells in the urine with red blood cell casts. And those are molds of the kidney tubules of red blood cells. Protein also escapes in the urine, but not as much as with nephrotic syndrome that we'll talk about later. We get a diminished GFR, and this is due to occlusion of the capillary lumen from that swelling and cell proliferation. And this leads to oliguria, which is decreased urine output, extracellular fluid accumulation, leading to edema, and hypertension. We also get azotemia, and this is the presence of nitrogenous waste in the blood. Because of the decreased GFR, the renin-angiotensin aldosterone pathway gets activated, and this leads to hypertension. Now, one type of nephritic syndrome is acute post-infection glomerular nephritis. This occurs primarily in children. It's actually fairly rare in industrial countries. And this occurs after infection with group A beta hemolytic streptococci from a sore throat, a strep throat, usually, or it can also be from a skin infection. Okay. It may occur with infection from other organisms, but it's usually with untreated strep infection. Okay, so this is a little like rheumatic heart disease. So, and like rheumatic heart disease, we get formation of antigen-antibody complexes, and it's those antigen-antibody complexes that do the damage, not the strep itself. This activates the complement system. We get an inflammatory response in the glomeruli. This leads to increased capillary permeability and the leakage of some protein and large number of red blood cells. This also causes congestion and cell proliferation, and this leads to the decreased GFR and retention of fluid and wastes. Okay, so let's look at some of the signs and symptoms. So we see facial preorbital edema, and this initially, and this progresses to generalized or widespread edema. Elevated blood pressure, and this is due to increased renin secretion and the decreased GFR. Flank or back pain, and this is due to edema and stretching of the renal capsule. General signs of inflammation, such as fever, malaise, increased white blood cell count. Decreased urine output, that's due to the decreased GFR. elevated serum urea and creatinine. That's also due to the decreased GFR. Metabolic acidosis. That's due to the decreased GFR. And if we look at the urinalysis, we'd see protein in it. We'd see lots of red blood cells creating kind of a cola-colored urine, erythrocyte casts, but no evidence of infection. Okay, nephrotic syndrome. So this also is not a specific disorder like nephritic syndrome, but rather a set of clinical symptoms resulting from increased glomerular permeability. It may be idiopathic in children 2 to 6 years old, may be secondary to lupus or exposure to nephrotoxins or drugs. But this is characterized by massive proteinuria of greater than 3.5 grams in a 24-hour period and hyperlipidemia. So let's look at this. We have glomerular damage that leads to increased permeability to proteins and lots of proteins in the urine. This creates low protein in the blood because they escaped the blood and got in the urine. That's going to lead to decreased plasma oncotic pressure, which is going to create edema. And the low proteins in the blood are going to cause a compensatory synthesis of proteins by the liver. And that's going to increase LDL proteins, and that's going to result in greater lipids in the blood, or hyperlipidemia. Blood pressure remains low or normal, may be elevated depending on angiotensin II levels. We can get some increased aldosterone secretion in response to reduced blood volume. So remember, it's this, because we have such decreased oncotic pressure, that leads to all that edema, so then there's less fluid in the blood, and that's going to lead to less, that's going to cause the blood pressure not to be so high. So even as we secrete aldosterone, then that's going to help to increase blood volume, but because of that decrease on oncotic pressure, that fluid's just going to leak out again. Okay, actually, you'll want to review the concept check, and it just reminded me that you'll want to spend a little more time looking at acute post-infection glomerulonephritis. And there is a case study regarding Johnny deals with this disorder. Okay, now we're going to look at obstructive disorders. Urinary tract obstructions. This can be caused depending on where in the urinary tract. We have some of the common causes of urinary tract infection. For instance, in the renal pelvis, kidney stones or renal calculi are a common cause. Pregnancy, tumors that compress the ureter, congenital disorders, bladder cancer, bladder stones, prostatic hyperplasia or cancer in men. Those are just a few things that can cause obstruction. What are the consequences of obstruction? Well, one, we can have stasis of urine. And if urine is not moving very well, then we have an increased risk of infection, and we also have the increased risk of kidney stones. This can also lead to hydronephrosis, as we mentioned earlier. So this is when we have expansion of the kidney with urine. And this increased pressure inside the renal capsule presses on the delicate tissues, leads to atrophy and ischemia. We end up getting hypertrophy of the opposite kidney to compensate, and this whole thing can end up causing chronic renal failure. Now, if we had acute bilateral ureter, so here's the ureters, obstruction, that could lead to pre-renal acute kidney injury. Kidney stones. They can develop anywhere within the urinary tract. And the stones can be very small or very large, as some of these are here. They tend to form with excessive amounts of solutes in the filtrate. Insufficient fluid intake is going to be a major factor because the fluid is so solute concentrated that they can develop more easily. Urinary tract infections is also another thing that can lead to the formation of stones. So manifestations only occur when there's obstruction of urine flow. This can lead to infection. This can lead to hydronephrosis. And if located in the kidney or ureter, atrophy of the renal tissue. Okay, there's different types of kidney stones and different contributing factors. For instance, calcium stones can be due to high calcium in the blood and high calcium in the urine. Could occur in like hyperparathyroidism, too much vitamin D, bone disease. Magnesium ammonium phosphate or struvite stones. This is caused usually by urea splitting urinary tract infections. Uric acid stones. This is formed in acidic urine. Gout, high purine diet. Cysteine, and we can have too much cysteine amino acid in the urine, and this is an inherited disorder. Okay, what are the manifestations of kidney stones? Well, stones in the kidney or bladder are often asymptomatic, but frequent infections can lead to investigation. Flank pain is possible, caused by distension of the renal capsule. But the big one is renal colic, if it's actually obstructing like the ureter. So renal colic can cause intensive spasms of pain in the flank area that can radiate to the groin. And this kind of goes in spasms as the smooth muscle of the ureter contract to try and push that stone through. Also associated with this, we can see nausea and vomiting, cool, moist skin, rapid pulse. Okay, and this is due to a sympathetic response. Radiology exam can confirm the stone. You can have blood in the urine and hydronephrosis. Benign prostatic hyperplasia. This is another thing that can cause obstruction in males. And this is where we have an enlarged prostate. And remember, the urethra goes through the prostate in males. And if this is enlarged, this can restrict urine flow. Okay, go ahead and take a minute to review the concept check. All right, next we're going to talk about learning renal failure, acute and chronic renal failure. Okay, so let's talk about what happens when kidneys fail. First of all, this can occur either directly through reduced blood flow into the kidneys or indirectly through inflammation and necrosis of the tubules, causing obstruction and back pressure. And this can lead to greatly reduced GFR, that's when the kidneys are failing, oliguria, reduced urine output, or anuria, which is no urine output. So less waste is removed, more waste remains in the blood. Nitrogenous compounds build up in the blood. We see an increase in the BUN, an increase in creatinine. The kidneys are unable to regulate fluid, electrolyte, and pH balance, so we see metabolic acidosis. We can see high potassium. We can have both acute and chronic renal failure. Let's start a discussion looking at acute. So acute kidney injury is when we have an abrupt reduction in renal function. So we see an elevated serum urea nitrogen and creatinine. But remember, actually I'm going to wait on that. Metabolic acidosis and hyperkalemia. A blood test reveal an elevated serum urea nitrogen and creatinine, metabolic acidosis, and hyperkalemia. Now, this is usually reversible if it is diagnosed and treated early. Dialysis might be used in order to help the patient get over the primary problem. So dialysis will function as in replace of the kidneys during that time. The classification of acute kidney injury is based on cause. Pre-renal causes, we have decreased renal perfusion. Intrinsic causes is within the kidney, when we have decreased tubule function. And post-renal is when the urine flow is blocked, leaving the kidney. Okay, so let's look at these two types. So pre-renal. So this is before the kidney. This is when we have a marked decrease in renal blood flow. So the kidneys themselves are not actually failing, but the GFR is low because the blood flow to the kidneys is low. We can see this in shock, congestive heart failure, dehydration, or vasoconstriction. Intrinsic is when we have damage to structures within the kidneys that leads to decreased tubule function. And this can be caused by ischemia. And ischemia could be caused due to a pre-renal failure. It could be caused by toxins or intratubular obstruction. Post-renal injury occurs when the outflow, urine outflow from the kidney is blocked. And this could occur with stones, tumors, or an enlarged prostate. Okay, so let's talk about the pre-renal acute kidney injury first. This is the most common form of acute kidney injury. And once again, that's due to a decrease in renal blood flow. This can be due to hypovolemia, such as it would occur with hemorrhage or dehydration, excessive loss of GI fluids, or a burn injury. This could be due to shock, where perfusion pressure is so low we're not adequately getting enough blood flow to the kidneys. Or heart failure, and that would cause the same thing. Other things that can cause decreased renal perfusion include sepsis, so septic shock, vasoactive mediators, drugs, or radiocontrast agents. So the perfusion pressure, we're just not getting enough blood into the kidneys. So this causes an abrupt decrease in urine output and a disproportionate elevation of the BUN in relation to the serum creatinine. Okay, so remember, because the nitrogen is still reabsorbed, but we're not filtering very much, but we can continue to reabsorb it. We can reabsorb a lot because the blood flow is moving so slowly because of the decreased GFR. Okay. Intrinsic acute kidney injury, also called acute tubular necrosis. So this is a result of conditions that damage structures within the kidneys. It's usually caused by ischemia from those pre-renal conditions, or it can be caused by nephrotoxins, such as drugs, heavy metals, or like in myeloma, multiple myeloma, those light chain antibodies. It can also be caused by acute renal disease. But it's characterized by destruction of these renal tubular epithelial cells, and they slough off and then obstruct the kidney tubules, leading to a dramatically decreased GFR. Post-renal acute injury results from obstruction of urine output. And this can be due to either bilateral ureter obstruction, so we have to obstruct, in order to have this failure, we need to obstruct both ureters at the same time, or we could obstruct the outlet, the urethra, the outlet of the bladder outlet obstruction. Okay, let's review those. Question, which type of acute kidney injury would be most likely to accompany benign prostatic hypertrophy? And that's going to be post-renal failure. Okay, and that occurs when the flow of urine is blocked by kidney stone, tumors, or an enlarged prostate gland. Okay, scenario. A man developed acute kidney injury after emergency surgery for a severed left leg. He came in with a serum creatinine of 1.2, but now it is 5.6. His BUN is 86. So, question. Why do you think the leg damage would cause renal failure? Well, let's take a look. So he severed his left leg. Okay, so he probably lost a lot of blood. So he had a sudden increase in his serum creatinine, and this would be due to pre-acute kidney injury. Now, in terms of what is his remaining kidney function, I just want to also point out, I didn't calculate this ratio, but this ratio of creatinine to BUN is higher than normal. Okay, the normal, it should be 1 to 10. what is his remaining kidney function? Okay, sorry, I just paused for a second to calculate that ratio. That ratio of creatinine to BUN is 1 to 15, so it's definitely increased. And that is indicative of prerenal failure. And then in terms of what is his remaining kidney function, the best thing is to go look at that creatinine graph. And I'm going to pause here and find it, and then I'll show you. Okay, so it said it was 1.2, so if we draw 1.2 out here, we see his percentage of normal function is 100%. It's normal. And now, though, it's 5.6. So we go to about 5.6 here, and we see he's at about 20%. 20% of normal functioning for an adult male. Okay, so that's the end of that scenario. Moving on. Chronic kidney disease. So acute, we have a sudden loss of kidney functioning. Okay, it could be due to pre, intra, or post renal failure. Chronic kidney disease, we have a kind of a progression of where we're losing nephrons over time. So with chronic kidney disease, we have fewer nephrons functioning, and we see a decrease in GFR greater than 3 months long. Now, as we have fewer functioning nephrons, the remaining nephrons must filter more, and that causes hyperperfusion of those remaining nephrons and hypertrophy. Eventually, we have an irreversible loss that leads to a permanent reduction in GFR. Now, you don't need to worry about these stages, but I just kind of wanted to point them out. Maybe kidney failure, you might want to know that. That's when we have a GFR of less than 15 milliliters per minute, and this is corrected for body surface area. Stage 1, I also want to point out we have kidney damage, and at first we can have normal or increased GFR during stage 1, and that can be due to this hyperperfusion of the undamaged nephrons. Okay, so this is a progressive thing, and as we see the progression, we should see a change in blood creatinine. Let's look at the causes of chronic kidney disease. The number one cause is diabetes mellitus, as we can see here on this graph. Next is systemic hypertension. So both these things are quite high. Other causes, though, include chronic glomerular nephritis, polycystic kidney disease, also shown here, low-level exposure to nephrotoxins over a sustained period of time would be another possible cause. So what are the manifestations of chronic kidney disease? Azotemia, this is nitrogen in the blood, so we see elevated creatinine and BUN. Uremia, that refers to urine in the blood, and this is when we are in end-stage kidney failure. We have uremia. Altered fluid, electrolyte, and acid-base balance. So this fluid alterations, it can produce dehydration or fluid overload depending on what's going on. An inability to concentrate the urine. Sodium wasting due to the kidney's decreased ability to reabsorb sodium. However, I'm going to point out in patients with hypertension, it's not advised to increase it because that can lead to increased vascular volume and heart failure. Hyperkalemia, remember, because the kidneys function to secrete potassium. So if they fail, they're not going to secrete enough potassium. Metabolic acidosis due to the kidney's inability to secrete hydrogen ions. Mineral metabolism disorders, we can get metastatic calcifications and bone disease. So if we have impaired phosphate elimination, that leads to hyperphosphatemia, that causes hypocalcemia, and that's going to lead to increased parathyroid hormone secretion. This is called secondary parathyroidism. And that's going to result in calcium reabsorption from the bone and greater bone loss. Decreased vitamin D activation, because the kidneys function to activate vitamin D. If that is decreased, that can cause hypocalcemia, and that's going to increase parathyroid hormone. This is going to lead to brittle bones and metastatic calcifications. We can also have the accumulation of nitrogenous waste because the kidneys aren't getting rid of them, or uremia. And that uremia can lead to pericarditis, impaired immune function, skin disorders, including dryness and itching, GI disorders, including anorexia, vomiting, and nausea, neurological disorders. We can get peripheral neuropathy, restless leg syndrome, uremic encephalopathy, sexual dysfunction, including impotence and hypofertility. Cardiovascular complications. We get anemia from hemolysis of red blood cells, bone marrow suppression, which is caused by the uremia, decreased erythropoietin because of the decreased kidney function, and iron due to some blood loss. And the anemia is going to cause weakness, fatigue, depression, insomnia, and so forth. Decreased blood viscosity associated with the anemia that can lead to increased heart rate and peripheral vasodilation, angina or other ischemia if it's more severe. We also get impaired coagulation and bleeding due to impaired platelet functions due to the uremia. And other cardiovascular complications include hypertension due to increased vascular volume, increased total peripheral resistance, activation of renin-angiotensin-aldosterone system, and heart disease. Okay, and this slide just kind of sums up all of those things: problems with sodium and water balance, problems with potassium balance, hyperkalemia, elimination of nitrogen waste. They accumulate, we get uremia, and that affects lots of things. Decreased erythropoietin and anemia, acid-base balance, we have problems with that, and that leads to acidosis. Activation of vitamin D is decreased, hypocalcemia. We don't eliminate phosphate, and that also causes hypocalcemia. This is going to cause hyperparathyroidism, and the parathyroid hormone is going to break down bones. End-stage renal failure. So as I mentioned, uremia, urine in the blood, the 3 A's, azotemia, anemia, and acidosis. We have very decreased GFR, so anuria or oliguria. Renal filtering function decreases. We have altered fluid and electrolyte imbalance leading to acidosis, hyperkalemia, sodium wasting, and hypertension. Waste buildup in the blood. We have increased creatinine and BUN. And this can be toxic to the central nervous system and to red blood cells and platelets. Kidney metabolic functions decrease, so we see decreased erythropoietin and decreased vitamin D activation. And at this point, we need to be on regular dialysis or have a kidney transplant. So how do we manage chronic kidney disease? Medical management includes controlling blood pressure, fighting urinary tract infections, controlling blood glucose, and quitting smoking. Dietary management includes trying to maintain optimal nutrition while minimizing some of the metabolic waste. So you want to avoid or restrict, I should say, protein, maybe sodium and fluid restriction. We're going to eliminate potassium and limit phosphorus. Dialysis and transplant with advanced uremia, or if you have really serious electrolyte imbalances. And dialysis could be temporary if you have acute renal failure. That should be temporary, or long-term for life until transplant in chronic renal failure. Okay, so let's look at hemodialysis. With hemodialysis, blood is going to move from an artery through tubing and a blood chamber in a dialysis machine, and then back to the body via a vein. Okay, so it's coming in here from artery, back to a vein, and then this is just showing the blow up of what's happening inside. So essentially, we have this dialysis solution that contains like water and bicarbonate. And if there are any needed substances the body needs, we could put that in the dialysis solution. Wastes are going to move, and any excess electrolytes, such as potassium, are going to move out of the blood into the dialysis solution. Now, most people are going to receive this hemodialysis 3 times a week, and it takes about 3 to 4 hours at a time. Okay, so they can do this at a dialysis center. Peritoneal dialysis is another type, and this is where the peritoneal membrane, which is really vascular, serves as the dialysis membrane. There we go. So here the catheter provides access to the peritoneal cavity, and we inject 1 to 3 liters of solution that is allowed to remain in the cavity and then is drained by gravity. There's a variety of treatment programs. Some are just like overnight. Some are actually ambulatory. Okay, and then you'll want to review, of course, the concept check. So this first time, we just have one video for topic 7. So we'll see you next for topic 8. Oh, I guess we should go through the scenario. So almost done. So we have a man with chronic renal failure. He has a high creatinine and BUN, hyperkalemia, acidosis with a normal PCO2. He also has severe anemia. His blood glucose has reached 340 milligrams per deciliter 1 hour after hospital meal. He complains of having broken 2 toes in the last few weeks, even though he eats a lot of dairy products for calcium. So what is the most likely cause of his chronic renal failure? Take a look. See what you think. Okay, if you guessed his diabetes mellitus, you'd be right. Number 1, that's the number 1 cause of end-stage renal failure. And 2, his blood glucose is quite high. Normal should be not over 100. What has caused his anemia? His kidneys are failing, so he no longer releases erythropoietin. Why are his bones brittle, even though he eats dairy products? So remember, he's no longer activating vitamin D. He has, so he's not absorbing enough calcium in the diet. That's going to stimulate parathyroid hormone. And then also, he's not going to be getting rid of enough phosphate, because the kidneys get rid of phosphate, and that's going to lead also to hypocalcemia and the release of parathyroid hormone. And then parathyroid hormone is going to cause the breakdown of bone to release calcium into the blood. All right, that's it.